Welcome everybody to today's acid-base seminar. Today I'm going to be reviewing the last two lectures, but in summary form, and make sure that everyone is aware of the six clinical acid-base rules that you need to know to be able to make a simple acid-base diagnosis. So we're talking now about single acid-base disorders in a patient, not more than one, or what we sometimes call complex acid-base disorders. And just to refresh your memories, there's six different acid-base disorders, each of which has their own rule, and these just have to be memorized. So it's pattern recognition, and the exercise is to see whether your patient has one of the rules that can apply to them. So just again to recap, when you're assessing the question of whether a patient has an acid-base disorder or not, you don't look at the pH. What you look at is either the total CO2 from the metabolic panel, comprehensive metabolic panel, or you look at the calculated bicarbonate from the blood gases. And in most patients, they're about one different. They only differ because of the level of the PCO2, as we showed before. So when you're asked what is the acid-base diagnosis, your mind should zero in on the total CO2 or the bicarbonate and decide then, is it normal or is it increased or decreased? If it's decreased, then 3 out of the 6 acid-base disorders could be present. It's either a metabolic acidosis or an acute respiratory alkalosis or a chronic respiratory alkalosis. And these are the names you should give the 3 acid-base disorders. Don't use the term primary or secondary, and don't just say respiratory alkalosis. You have to, before the respiratory word, you have to say whether it's acute or chronic. So these are the 3 where you find in a patient that the bicarbonate or total CO2 is decreased. But recall also, not only is the bicarbonate decreased, but the PCO2 is decreased. So in all 3, they both have a directional decrease in both of the important values that we're going to assess. Or the total CO2 or bicarbonate could be increased. And again, you have the remaining 3 out of the 6 acid-base disorders. It's either a metabolic alkalosis, acute respiratory acidosis, or chronic respiratory acidosis. And the same terminology applies. Don't use the words primary or secondary. And remember, if you're saying respiratory, in this case acidosis, you have to have the temporal word before it. It's either acute or chronic. They're very different as far as their diagnosis. And again, in all 3, not only is the bicarbonate increased, but the PCO2 is increased. So in both groups, you have the same directional change in your bicarbonate and PCO2. And now what we have to do is somehow distinguish which of the 3 it is in each of these 2 categories. And for that, we have to apply the so-called acid-base rules, because each of these 6 acid-base disorders has a different rule. And the rule that we look at, or the mathematics that we're looking at, is what we need to do now is to calculate the change in the bicarbonate from its original value and compare it to the change in the PCO2 from its original value. That's what the rule refers to. And each of them has a different change in bicarbonate from its original value relative to the change in PCO2 from its original value. Now, the problem is we don't know the original values in most patients, so we have to assume population norms. And remember that the normal PCO2 in a male is 40 and the bicarbonate's 24. And in a female, the normal PCO2 is around 38 and the bicarbonate's 23. So unless you have the original values in your patient prior to the acid-base disorder, you have to assume population normal values. And that we do with everything. We do that with the anion gap, etc. We always assume typically population normal values because we don't have the normal value in our patient. If you have the normal value in your patient, that's the best thing to calculate deltas from. So the question is, you have a patient now with a change in bicarbonate to change in PCO2 of 1 to 1.2, or it could be 10 to 12. This is just the ratio of the 2 numbers. The 2 numbers could be anything. So which of the acid-base disorders has this ratio? Does anyone want to unmute and tell me which of the 6 has this?
Metabolic acidosis?
Yes, correct. So this is a metabolic acidosis. Sorry, it should be showing that. It's not. Okay, so the metabolic acidosis is the answer here. For every 1 change or 10 change in the bicarbonate, the PCO2 changes a little more. Or you can memorize the Winters formula, which also has an intercept, but you don't need to. If you just remember that the only disorder where the changes are approximately identical, it's metabolic acidosis compensated. Okay, here's another ratio. The change in bicarbonate to change in PCO2 is 3.5 to 10 or 7 to 20, that sort of thing. Which disorder has this ratio?
Chronic respiratory alkalosis?
It's actually acidosis. So
Yes.
just remember conceptually that if you're not sure which of the 2 it is, that the changes in respiratory alkalosis are greater. The ratio is actually greater, both for acute and chronic respiratory alkalosis. Why that is just the way our brains and ventilatory system are constructed. It's not clear why. So the ratio is actually a little lower, both acute and chronic respiratory acidosis. So this is what you would see in someone with COPD, for instance, chronic bronchitis. What about this ratio? Twice as much. This could also be 1 to 2. I just happened to write it as 5 to 10. It's really 0.5.
This is chronic alkalosis.
Yes, so this is a patient with chronic respiratory alkalosis. It could be a patient with end-stage liver disease, someone who lives at high altitude, a woman during her pregnancy, or someone with emphysema. Those would be the common clinical reasons. So someone who's chronically hyperventilating, I'm not showing direction here, which would also provide you, it would help distinguish the two major categories, which of the 3 it fits into. But each of them has a different ratio anyway, so we don't really need to show arrows that, but in this particular case, both are going down. Okay, here's another patient with a ratio of 2 to 10 or 1 to 5. And also, I'm not showing cause and effect here. In 3 of them, it's the bicarbonate that changes, and then the PCO2 changes, and or in 2 of them. And in the other 4, it's the PCO2 that changes first, and then the bicarbonate changes. So in the respiratory acid-base disorders, the PCO2 is changing, and then that's causing the bicarbonate to change. In the metabolic acid-base disorders, it's the bicarbonate that changes, and the PCO2 changes after that because of changes in ventilation. So I'm just showing at a point in time what those deltas are. We're not showing the temporal component because this ratio doesn't occur suddenly. It takes time, which we'll show in a few slides from now. But at any rate, if you find a patient with a change of 2 to 10 or 1 to 5, which of the acid-base disorders is it? So this would be acute respiratory alkalosis, and the causality is that for every 10 change in the PCO2 from hyperventilation, the bicarbonate changes by 2. Both are going down. And remember, in the acute respiratory acid-base disorders, you don't need an organ for this to occur. It's because of the shift in the bicarbonate buffer system, exactly as if you opened a bottle of a carbonated drink. The bicarbonate concentration would fall because the PCO2 fall shifts the buffer reaction. So here's another patient with a change of 10 bicarbonate and a change of 7 for the PCO2, or 20 to 14, or 5 to 3.5, whichever ratio you want to memorize, or 0.7 if you want to do it that way.
That is metabolic alkalosis.
Yes, very good. So this is you only see this in metabolic alkalosis. For every 10 increase in the bicarbonate, the PCO2 will go up by 7, and that's because we hypoventilate. It's also called the respiratory compensation in metabolic alkalosis also. Very good. And here for every 10 change in the PCO2, again, I'm not showing directionality here, but we're just showing the ratio of 1 to 10. This is acute respiratory acidosis as opposed to acute respiratory alkalosis, where it was 2 to 10 in respiratory alkalosis, whereas it's 1 to 10 in respiratory acidosis. So if you that's sort of a hard thing to remember. Just remember in the respiratory acidemic patients, either acute or chronic respiratory acidosis, the ratio is lower than the ratio that you get in respiratory alkalosis, both for acute and chronic, and that will help distinguish. So if it's 3.5 to 10, that's acidosis. If it's 5 to 10, alkalosis. If it's 1 to 10, acidosis. 2 to 10, alkalosis. It's sort of a quick way to remember. Otherwise, it's hard to keep it in your mind. So here's a patient who had an original bicarbonate of 24 and it fell to 15, and the PCO2 that was originally 40 fell to 22. So the changes here are 9 to 18, or 5 to 10, or 1 to 2, or 1 to 5, excuse me. Or 1 to 2, sorry, 1 to 2. Or 0.5, whatever you want to memorize. Or 50% of the original 100%. So which of the acid-base disorders has this change?
So there's a decrease in bicarb, bicarb on the gas or total CO2 on the BMP. That's either metabolic acidosis or acute or chronic respiratory alkalosis.
Right.
Um,
That's the category you're talking about. It must be one of those three, not the other one.
so the 5 to 10 would be the chronic respiratory alkalosis.
Very good. Beautiful. That's exactly how you do it. So the only acid-base disorder this could be is chronic respiratory alkalosis. And we have our 6 again, but the answer is D. And that again could be a patient with end-stage liver disease, emphysema, someone living at very high altitude, or someone during their pregnancy. It's important to know the high altitude case, because if you're a renal fellow living in a place at high altitude, the normal patient has chronic respiratory alkalosis. And so everything that changes is above that. It's always, in a sense, a mixed disorder, because their baseline acid-base they have a baseline acid-base abnormality. So it makes things more confusing. Okay, what do you think's going on here? And again,
It's the
it's blood
same
paradox.
category, so it's either metabolic acidosis or acute or chronic alkalosis.
Right. Same.
It's 7 to 10, correct?
That's correct. Well, actually 8 to 10.
8 to 10.
They're close. They're almost the same change for
Yeah.
each.
So that's metabolic acidosis, 10 to 12, basically.
Very good. So this is a patient with metabolic acidosis, either anion gap or normal anion gap. They have the same acid-base changes. And when the bicarbonate falls, we get this additional increase in our ventilation, and a normal human being has a fall in the PCO2 of roughly the same. It's a little more as far as the units. It's 1.2 to 1. Obviously, the units are different.
Dr. Kurtz, I think the challenge is just to kind of do the ratio in the beginning. That will probably take some time on the exam.
Yes. Yes, it is the challenge. It is. And you can use whatever ratios you want. You can use 1 to 1.2. You can divide 1 by 1.2. But yeah, I mean that's the challenge that we face. I would just look, there's a ton of cases and numbers online. I can give you more if you like, but eventually you get fast at it. It should be something that becomes automatic, like driving. This shouldn't be part of your exam where you have to use a lot of thinking. Once you create the approach of looking at the bicarbonate and the PCO2 and ignoring the pH and looking for looking for the delta for each and calculating the ratio, it eventually will become automatic. The problem for a lot of people is unlearning all the previous approaches they used, or they have mixed approaches, and it gets very hard. But if you have one single approach and pursue it, and use only that approach, eventually it'll become automatic. You won't have to use a lot of your mind and waste a lot of time. You know, diagnosing the dysnatremias and knowing what's going on with sodium is much harder than clinically than the acid-base disorders, it turns out. So this is compensated metabolic acidosis, like you said, correct? Okay, here's another case. So here the bicarbonate went up by 10.5 and the PCO2 went up by 30. And again, if you want to come up with another approach and just say you're looking for something, this patient has 0.35 as a ratio, you won't have to go, to 3.5 to 10. You can just take the 10.5 over 30 and it'll be 0.35 and it'll be a single step.
This is chronic respiratory acidosis.
That's correct. Very good. So that's a patient with COPD or someone with a neurologic disorder where they're hypoventilating chronically. So here the bicarbonate changed by 2 and the PCO2 fell by 10. One of the problems clinically is a lot of people would look at this and say, yeah, the bicarbonates didn't change. I mean, they'll say it's a trivial change. That's a common problem that people don't, it's like the creatinine. If it's 0.7 and goes to 0.9, a lot of doctors will miss that. But the bicarbonate, if you actually measure it in a single human being, very accurately, is actually kept within the decimal point from day to day. So if you're let's say one of you has a bicarbonate of 20, and we're rounding it off here is 24.3. It'll be 24.4 or 24.2 tomorrow. It really doesn't change much. Whereas when you look at the laboratory slips, it gives such a huge range for bicarbonate and the total CO2 on the comprehensive metabolic panel, you'd think that two things. One, there's that wide range, which there isn't. And secondly, that a normal human from day to day, a single individual, can swing from one of those numbers to the next and still be called normal. And it's just not true. Part of the challenge is being able to perceive that you're dealing with abnormality. That forces you to have to think. So making a diagnosis of, yes, these numbers are abnormal is also part of the challenge. And oftentimes they're just missed. So here the bicarbonate truly changed by 2 and the PCO2 fell by 10. So, you could say that the ratio you're looking for is an acid-base disorder with a ratio of 0.2 if you want, or 1 to 5, whatever is easiest for your mind to memorize. Some people like converting them all to decimal points.
This is acute respiratory alkalosis. Correct.
So it's, again, the hard one to remember because then the change is similar for acute respiratory acidosis. One is always alkalosis, chronically and acutely. So if this was acidosis, it would be 1 to 10. So that's correct. Very good. So here the bicarbonate's gone up by 10 and the PCO2 has gone up by 7. And also you can tell from these numbers if it's male or female. So this must be a female. You don't see a PCO2 of 38 normally in males, or bicarbonates of 23. And you need to remember that because otherwise your deltas will be wrong. Unless you had, like this patient, you had normal numbers to begin with prior to the disorder happening.
Yeah, this is acute metabolic alkalosis.
Well, metabolic alkalosis, remember, we don't divide by time.
Yeah, metabolic alkalosis.
Yeah, it's metabolic alkalosis and it's compensated. So for every 10 increase in the bicarbonate, let's say you start to vomit now, or some doctor puts an NG tube down, so you NG tube suction, and I come back tomorrow and your bicarbonate's not 23, but 33, I would expect that if you have normal lungs and normal medulla and normal ventilatory system, your PCO2 would have gone up 7. So roughly the changes are 10 to 7. Some people, you can flip the ratio too if you want. Some people like putting the PCO2 in the numerator and the bicarbonate in the denominator. Some people like putting the initiating cause in the numerator. So there's many ways to do this, but just come up with an approach that's easiest for you to do conceptually, and also that's the fastest for you. And you should time yourself too when you're going through these. If with your problem sets, try not only to be accurate, but to achieve speed, so that you spend the minimum amount of time coming up with the correct diagnosis. And again, the more you do, it'll eventually become automatic for your mind. So that was metabolic alkalosis compensated. So here again, we have a very small change in the bicarbonate. Many people would miss that and say, oh, bicarbonate of 27, that's normal. Why are we even talking about something? And one of the clues is that the PCO2 has changed significantly. So you would expect that there would be some change in the bicarbonate. If the PCO2 was 42 or something, then you could probably ignore everything. But here we have an increase in the PCO2 of 20, and the bicarbonate went up by 2, or 1 to 10, or 0.1 if you want to use that instead. So what acid-base disorder?
So this would be acute respiratory acidosis.
Correct. That's correct. So again, it's a smaller ratio.
Dr. Kurtz, I feel like this is useful for like exam where like everything, all the tests are like done perfectly, but I feel like clinically it's hard to assume that like everything's going to be perfectly drawn and perfectly accurate, right?
Right. So this is an excellent question. And it really comes down to, in the real world, how much deviation from these ratios will you accept? And that is more a feel based on the clinical situation and just experience. So, but you're right. In the real world, they're not as perfect as this, and so it does become harder. I would say, if it's within 10%, or 10 or 20% of this ratio, then you'll accept it as a simple acid-base disorder. And if because it's a very important question, because of the question can also be rephrased. When do you assume that there's more than one acid-base disorder present? Because if it's not one of these 6, by definition, you have more than one acid-base disorder. You don't know how many more you have. It could be 2 more, 3 more, 4 more, but it can't be one of these 6 primary, or we call primary or simple acid-base disorders. So it's a very important question. Yes, the real world is messier. Now, there's 2 reasons for it being messier, or probably more than 2 reasons. One is that this is an average for a large population that people have studied over the years. So when people came up with these ratios in the 60s and 70s, they studied large numbers of humans and took an average. So, and there was a standard deviation. And so not every human, even if the labs are drawn perfectly, has these ratios. That's probably more of a problem than the labs being in error. Of course, that could be also that technically there was something wrong with the measurement. But typically, the reason that these numbers don't fit perfectly in every given individual is because this is an average value. And so, if you want, you can go back to the original papers, and I can actually get that for you to save you time and give you the standard error of these ratios. And that would be typically one way of addressing your question, that if you took 20 people, what would be the spread of the ratio for acute respiratory acidosis? And that's probably what, you would do clinically to assess whether the patient has that and the ratio is just a little bit different because each person is a little bit different, or there's another acid-base disorder present. But you bring up a very important point.
Great, thank you. And then we're going to talk a little bit later about how to do these like 2, 3 base, 4 base
Yes, yes.
problems.
So after today, the next lecture is going to be on complex acid-base disorders. So today will be the last lecture on the simple acid-base disorders. The next lecture is going to be on how to diagnose when there's more than one present.
Also, Dr. Kurtz, I have a question about, as you said, there's other approaches before fellowship. The rule of plus minus 2. Do we kind of apply that here, or just because one of the examples you mentioned were like only 2 change? So I feel like the rule of plus minus 2 wouldn't apply in
It
this
wouldn't.
approach.
It wouldn't. I think it's overly simplistic. Basically, what you want to know from the original papers is what's the standard error or standard deviation, or they have confidence intervals. They come up with an equation looking at the delta PCO2 to delta bicarbonate at different values, and then they have a regression line going through, let's say, 40 or 50 patients to get a slope and intercept. And what we're showing here in these rules is the slope. And then they have confidence intervals above and below, and that's the sort of range you get between different people. And that's really what you should be applying clinically. I'll try to get those for you and send it to all the fellows. Okay, so the other important point is that these rules don't occur instantaneously. There's a temporal component. So, for instance, when you get a metabolic acidosis, you have to wait until you get a 1 to 1.2 ratio. It doesn't, the ventilatory response doesn't occur instantaneously. And you won't get this number until you've waited long enough, till you reach a new steady state. Prior to that, it'll be another ratio, and that's what confuses people. Sometimes they try to make a diagnosis earlier than they should, and it looks like there's more than one acid-base disorder present. It's just because they haven't waited long enough for the acid-base disorder to reach a new steady state after the initial change. No matter which of the 6 it is, you have to wait the appropriate time, some more, some less. So that's what I want to review now. Which acid-base disorder do you have to wait 2 or 3 days until a new steady state is reached? Each of them has a different time, and you can memorize that too, if you want to know when you should make the new diagnosis. So it's chronic respiratory alkalosis. If I start hyperventilating you now, it's going to take 2 or 3 days before the change in the PCO2 will be double the change in your bicarbonate. So if I drop your PCO2 to 30, let's say it's 40, it's going to take 2 or 3 days for your bicarbonate to fall by 5. So 2 to 3 days is chronic respiratory alkalosis. What takes 24 to 36 hours? These are hard, so I'll just go through them. It's not something you would necessarily be aware of. That's metabolic alkalosis compensated. So the ventilatory response in someone who's vomiting or NG suction, whatever the reason is for the acute metabolic alkalosis, takes about a day to a day and a half till your ventilation is such that you reach a new steady state. So let's say the bicarbonate went from 24 to 34, the PCO2 would take a day to a day and a half to reach 47. Prior to that, it's going to be less than that. And so you'll be fooled thinking the patient's not compensating appropriately until you wait long enough. What takes about half a day to a day? Well, it turns out that's metabolic acidosis. So the compensation of metabolic acidosis, let's say you get diabetic ketoacidosis now acutely, it's going to take half a day to a day till your PCO2 drops to match what you'd predict for the Winters formula or 1 to 1.2 or whatever rule you memorize. It doesn't occur instantaneously. And that's the concept here, that these rules take time, some in the time frame of days, some in the time frame a few days, and you'll see in a minute some of them just take a few minutes. So the acid-base disorder that takes the longest is chronic respiratory acidosis. And that sort of is the opposite of the rule I told you for the ratios, where here the longest absolute value is for chronic respiratory acidosis, not alkalosis. Chronic respiratory alkalosis achieves a new steady state sooner. Here, what's happening is that with the elevation of the PCO2, the reason the bicarbonate goes up is the kidney has to change a lot of pathways that it's normally doing. It has to generate new bicarbonate in the proximal tubule, plus it has to reclaim all that additional bicarbonate that's coming through your glomeruli. So there's a generation of new bicarbonate issue by the kidney, and there's changes in the transport processes that the proximal tubule predominantly is using to reclaim the bicarbonate. So in a certain sense, the rise in the bicarbonate in chronic respiratory acidosis has the same two types of concepts that we have in metabolic alkalosis, where we have a generation and a maintenance phase in metabolic alkalosis. The same thing is occurring in chronic respiratory acidosis when the bicarbonate goes up. Because normally if I gave you a bicarbonate load, if I gave any of you a bicarbonate IV, you would just pee it out. I would be transiently increasing the filtered load of bicarbonate through your glomeruli, but it would end up in your urine. Whereas in chronic respiratory acidosis, yes, you have the high filtered load, but it's not coming out in your urine. That's why the blood level continues to go up until a new steady state is reached after 3 to 5 days. And then we have acid-base disorders that take only minutes to reach a steady state, and that's the acute respiratory acid-base disorders, either acidosis or alkalosis, because here it doesn't require an organ. You're just shifting the bicarbonate buffer reaction. Is that exactly as if you're pumping carbon dioxide into water with SodaStream or whatever device you have, or analogous to acute respiratory alkalosis, you're removing the carbon dioxide acutely from the solution. Okay, so let's go to some cases. Here's a 58-year-old male who's vomiting, and the 35 is the total CO2 from the comprehensive metabolic panel. The bicarbonate of 34 is from the calculated bicarbonate from the blood gas machine, and the PCO2 is 47. And again, note, I'm not putting the pH here because you don't need it. And if you want to, you could calculate it using the Henderson equation, where hydrogen ion concentration equals 24 times the PCO2 over the bicarbonate.
I can try to.
Sure, go ahead.
So the bicarb has increased by 10, and
Very
the
good.
PCO2 by 7. So this is either acute metabolic alkalosis or acute or chronic respiratory acidosis. The rate is 10 to 7, so this is probably metabolic alkalosis.
Yes, that's correct. And again, note that in answering this, we don't have the original values, so you correctly assumed the population norms for a male. And again, just know that that's an assumption, because your PCO2 may not be 40. You may be chronically walking around with a PCO2 of 41 or 42 or 39. There is a standard error, standard deviation, and papers have been written on this where people have measured blood gases in just normal humans, and not everybody is 40 and 24. Realize again that that's a mean, but you don't have a choice here because you don't know this patient's previous blood gases. The only thing you can is just the same thought as anion gap. You just have to assume the average value for the population. Yeah, so you're correct. That's good. So here's another patient. So when you do the math, you see that it's 10 to 12 or 1 to 1.2. Again, essentially the changes are almost equal. That's another just sort of conceptual clue. What acid-base disorders has the change in both values almost the same number? And this patient, we don't know again what the patient's original numbers were, so we assume we're getting 10 to 12 or 1 to 1.2 by assuming 40 and 24, which is an assumption.
Compensated metabolic acidosis from decay.
Yes, correct. Very good. And again, I'm not for today's lecture, but something you already know, that this delta delta is the same whether the anion gap's elevated or not elevated. But that would be another subcategorization you want to do in any patient where you say that. You would want to know, is this an anion gap metabolic acidosis or a non-anion gap or so-called hyperchloremic metabolic acidosis, whatever term you want to use. Yeah, very good. So here's someone who had an acute anxiety attack. And these are the changes from normality. Again, you could use 1/5, or you can use 0.2 if you want. So there's only one acid-base disorder that has a change with these ratios. Again, we don't know causality. We don't know what's changing what, but the only acid-base disorder with this is where the PCO2 changed and then the bicarbonate changes after that. And then you see this in, again, this is acute respiratory alkalosis, which you might expect clinically also from the anxiety episode. But note again, for those that are just starting to think this way, when you see this, you might start thinking, well, is this metabolic acidosis with compensation, or do they compensate too much? Is there a mixed disorder present here? Because typically when medical students or residents see a drop in the bicarbonate, the only thing they think of is metabolic acidosis. But remember, there's two other acid-base disorders that can drop your bicarbonate. So it's important to always either in your mind or write down 3 choices if the bicarbonate's down and 3 choices if it's up. So this is acute respiratory alkalosis. And again, the change, final steady state occurs in minutes, and it's totally due to the bicarbonate buffer reaction, and analogous to opening up a bottle of Coca-Cola and seeing the bicarbonate drop as the PCO2 drops. So here we have a bicarb of 34.5. The decimal here is not just for teaching, but also just to remind you that we tend not to think of the bicarbonate being accurate to the decimal point, and it's just because of the way the clinical lab reports things. It actually is accurate to, just like creatinine. We get the second decimal point. So the changes here are 3.5 to 10. And again, we have an increase in the bicarbonate. Don't just think of metabolic alkalosis as the cause. We have 3 possibilities, all differentiated by what this ratio is. But there's only one that does this. I might mention to you that Nick Medias, who just passed away, he was one of the giants in the literature in acid-base studies and what the numbers were in humans. after a number of years, has reported, and there's only one paper suggesting that there were errors in the previous studies that looked at what this ratio should be in chronic respiratory acidosis. And he was suggesting it's more like 0.5. It's more like this would be 5 and 10. It's more like respiratory alkalosis. And so that has not been solved yet. It's unclear, but so the literature is confusing as to what, just know in your mind that if you do see a patient and it's 0.4 or 0.5 in the up direction, this may not be something strange. It may be that Medius was right. The paper was published, I think, 6 or 7 years ago. It was very surprising. But in the group of patients he studied, he got a higher ratio. So chronic respiratory acidosis. Okay, everyone, I think it's a little bit early, but we'll stop there for today. In the next lecture, I'm going to now assume that we've covered, at least to the best of my ability, the simple acid-base disorders, and we'll move on now to how you approach a patient in the real world with more than one acid-base disorder present. And just remember also, we'll review cases where the numbers look completely normal. So as we'll show in the next lecture, you can have a patient with a bicarbonate of 24 and a PCO2 of 40, and they actually have more than one acid-base disorder present. And that brings up the point that we're always looking at net values. So normality doesn't mean the absence of acid-base disorders. And we distinguish osis, the word osis, from emia. So emia is just a description of the acidity of your blood. Osis is a process. So for instance, you can have a metabolic acidosis and a metabolic alkalosis, and they're equal in magnitude, and you end up without acidemia or alkalemia because the effect on the bicarbonate and the PCO2 were in opposite directions, but quantitatively identical, and the patient has a bicarb of 24 and a PCO2 of 40. And often in those cases, the only clues you have that there's something else going on is you have another electrolyte abnormality like a dysnatremia, or your potassium's not normal, or there's a change in the anion gap. You have other clues. But that's a scenario that you can get on your exam also. Completely normal numbers, but a mixed acid-base disorder that we'll cover in the next lecture. And there's many clues and approaches to how you diagnose mixed disorders. Does anyone have any questions about what I covered today? Okay, everyone, thanks for joining, and we'll see you next time.